Now I would like to introduce our keynote speaker, Associate Professor Lisiane Pruinelli. Dr. Pruinelli is an associate professor and a clinical informatics researcher at the University of Minnesota School of Nursing, where she also earned her PhD degree and teaches statistics and health informatics for undergraduate and graduate students. She's also a fellow of the American Medical Informatics Association, and her research leverages innovative nursing informatics tools and cutting-edge data science methods to investigate acute disease conditions such as liver transplantation and sepsis. Her research uses multiple source electronic health data to discover new knowledge using a holistic approach to health, incorporating psychological, psychosocial, and other determinants of health. Professor Pruinelli, the floor is yours.
Thank you very much. Thank you very much for the introduction. And I would like to thank everyone, the organizers and Greg, that is not here right now, but for the invitation and the opportunity to challenge you a little bit about what means or what we have been questioning about explainable AI in healthcare. This session will give you more questions than answers probably, but that's my way of working. As on my introduction, I'm from the School of Nursing, and I started at first I used to teach stats to nurses, so you can tell that I have to have some juggling around to the field. Nowadays I teach data science, so I did a little bit of, I guess I was challenging a little bit more towards the years. So who is a clinician in this room today? We have one. Okay, great, wonderful. I was expecting to have one or two or none, so that's wonderful because my presentation is intended to non-clinicians, I believe so. And please, if you feel like interrupt me anytime to raise any question, please do so. So I don't have anything to disclosure for this presentation. In this talk, I'm planning to give a little bit of understanding of what it is healthcare practitioners, healthcare clinicians, and how we work, about the uncertainty in medicine and how AI adds to this unknown that clinicians face every day when they take care of patients. The current state of the data available for us doing modeling and machine learning, AI, and so on. And what are the data-driven explainable AI that, from my perspective, are the main drivers of what we cannot actually explain in AI nowadays. So I think first to understand a little bit how healthcare works and how clinicians work, nurses, physicians, and other healthcare professionals. We made an oath every time that we graduate and every time that we face clinical decisions that first do not harm. And that is historical and didn't change. And second, we want to improve people's life. So always we keep that in mind in everything that comes to us, in the sense that we deliver to patient care. We want first not to harm patients, and second, we want to improve their life. So the uncertainty, clinicians deliver care based on probability, and I'm sure you have a lot of knowledge about probabilistic theory and so on. And clinicians deliver care based on what is the probability that you survive, what is the probability that you will stay longer in the hospital or not, what is the probability that you have cancer, what is the probability that you live longer. So that uncertainty is not is current and is always there. We always, we are never 100% sure of everything. And we care, we deliver care to people based on that probability, uncertainty of what will happen next. And that is, comes to the sense on things that we build during our training. So first, we see things, we touch things, we smell things. It's how we train. We have anatomy class where we touch bodies. We go to chemistry class where we do reactions and we see reactions happening. So we are using and trained to see things, to visualize things. And based on that learning, we will deliver care. And you may think about, what she's talking about? Because that is the foundation about why it's so hard to implement AI in healthcare. And you may think about, but the modeling is performing well, is everything well. But you have to think about, from a clinician perspective, how is a totally shift on what they learn, how to understand disease progression and how to predict what can be happening next. That is different than what they have as a cultural understanding of what is learning in education. And then is how they learn. They learn touching bodies, understanding muscles, nerves, bones, and so on. And that was one of the first classes that they took a picture and how it used to be in the past. So there was a table, a human body there, surgery, people performing a surgery, and the students looking over that and seeing what happened. That's how they learn how to perform a surgery. And things have changed over time. Now we have mannequins. Maybe it's kind of almost getting old, but it's still visualizing things. It's still replicating the presence, the physical, the human body. Nowadays, we have more virtual reality to use that, but still that virtual reality has a shape. You can see, you can visualize, you can touch in some sense and feel how it goes. And if you think about robotics, that is kind of, for a couple of years have been used for surgery, they still can have that sense of replication of movements, of visualizations in the body and so on. So I think that is very important to understand when we talk to clinicians and how we explain what we do, the way that they see and the way that they can process all this information that we have, and how can we, as people that develop models, that develop complex models that we don't see per se, right? But how can we actually transform that knowledge into something that is more palpable at the clinician side? So there are multiple applications of AI in healthcare, and all these applications promises to alleviate the impact of disease on people. Promises as well that will be more cost effective. But still, AI is not a universal solution. In many fields that we have been trying to implement AI, we have been struggling a lot with acceptance, with the trust, and how people use that. So the technological progress goes always hand to hand. We always have novel questions. We have significant challenges in healthcare. Things are much more complex than just to predict if you will buy a Tesla tomorrow or a Ford tomorrow. We have many more confounders to play into that. And many things we don't know how things progress differently. Is this trajectory? Not just because you have a certain situation right now, a symptom or a sign, that means that you progress the same way that the other person that is just sitting by you and has the same symptom. All these conditions, all these considerations, and all this variability we need to consider when we model, and how we explain, how you capture those variations in a more complex model, as, for example, deep learning. So AI in healthcare presents great opportunities, of course, and we know that mostly who works closely with machine learning and who work close with some clinicians. There are a couple of clinicians that believes that this is a great thing that we need to implement, that we need to move, and there is a chance that the AI will explain and will provide some solutions that we don't have any clue nowadays. But this is still is a bigger field, and we have a lot of questions, and many fields are not open to new and challenging ideas. And also we have challenges including users to the entire process, training, scalability, algorithm bias, and interpretation of these models. So how can we explain what we do to clinicians? Can we explain the AI-driven process into medical terms? I think that's the question that we should ask ourselves, and the question that I ask to myself every day that I develop a study, I develop a model, and I talk with my collaborators at the clinical side that they don't have an understanding of technology modeling the way that we have when we develop. And I think there are several aspects that we need to consider, and I will bring some here. There are technical aspects, there is the meaning from the start to the end that they want to understand, the legal aspects, the social aspects, and the ethical aspects. And all these aspects, many are unknown. Not that they are known for who developed the model, but they are unknown in a medical perspective, in a way that when you take care of patients, how you address that, considering all these aspects. So the technological aspects, can we explain the method? This is the first question. How do you explain the method? There are inherent characteristics of this method that is important to explain. How explainable it is, how general it is, how accurate than other methods available outside is the method that you are doing. One way that is very effective in showing to clinicians your model is to use similar models that they use more currently. For example, regression. Regression is a model that every clinician knows how it works. So if you can show your deep learning model or your machine learning model into some more simple method and how that can be transferable to that situation, we will be much more receptive, much more welcome that method than actually you go there and explain, oh, I did this fancy deep learning LSTM model, and then I showed that this gave that. They will just give you their backs and say, okay, I'll talk to you later. They will not listen to you. So you need to talk in a more accessible language. There are considerations that we were not very lucky in some things. I know that we pay a lot of attention in how well perform our models, and that is a key for us. But where that performance comes from? Is a metadata or from the data itself? And probably every one of you remember that clever hands phenomenon that is about the husky and the wolf, that was actually able to capture the husky and make mistakes because actually it was not capturing the animal per se, but was capturing the white snow in the back of the husky. So if you were putting the wolf in front of a white background of the snow, we'll read as a husky. So this kind of things stay in clinicians' hands, like how the machine learning, how the deep learning, how the AI will identify, and how it's trained in a way that will actually do the right decision at the point of care. So the legal perspective, so the data is acquisition, storage, transfer, pre-processing, the analysis, how that will comply with the laws. We have a lot of laws, regulations, and requirements for using healthcare data. How that will be following the same laws or not is actually not very clear if we will following the same laws in the way that is used nowadays, or not when we are using the same data for developing an AI. In the absence of general rules, we try to identify data information, but like patients, when they consent to donate or to make their data available for research, they are aware that that data is also available to develop an AI. Should we add that to that consent or not? So it's not just about keep doing, but we have a lot of patient perspective. And when you think about some very ground rules that we have when we think about preserving patient privacy and confidentiality, when AI opened a totally new world of questions. And those questions are specifically due to these mistakes that I think AI kind of did and was very popular, like the husky, the wolf, or seeing a white face and black face. And so those kind of things stick on people's mind, and people are afraid. And this afraid feeling is because of the lack of understanding, not understanding how that decision is made, the process inside, and not seeing the process, not being able to justify that. How the certifications will work, how the FDA will regularize all these AI applications. They will legalize one, and then you have to refine, you have to submit again. It seems that is how it works nowadays. So how is not, I remember at some point in the past, and I promised that I will be in time. Well, I don't know about that, but I try and do my best. But I remember when we used to work with paper EHR, like it was not EHR, it was paper documentation in the hospital. And then when came the technology, we thought it was just transfer all those papers in the same format to electronic format, it will be good. Nowadays, we found that that is a mess because we just have replicated work everywhere. Actually, you have to do it in a smarter way, in a computer-friendly way, not the same way that we used to do in paper. So how now we do with AI will be the same as actually getting a certification for a blood pressure mesh or a thermometer. So those kind of questions are questions that we don't know, and the agencies, they don't know, the rule makers, they don't know who will be liable if there is a mistake. That's a question that people ask. If you are going to the healthcare and you have an AI making a decision, and the clinician will go for that decision, who will be liable if something goes wrong? Will be still the clinician? Or you just say, oh, the AI did that decision, I don't have anything to do that. So how do we make AI and clinicians work together and still be a common shared decision in a way that the clinician has the knowledge to decide, excuse me, to decide if that AI application is actually giving the right direction for that patient or not. So that is the question that lay on the ground of all these applications. So how the system arrives at conclusions in general is how is where we want to achieve some more clear understanding. How the models select features, why one feature is more important than the other one, how much more important is. Those questions we want to know. Which features were important for an individual prediction? Which ones will generate false predictions? How many false predictions can I expect or not? How do we explain to doctors that will then explain to patients all this process? Nowadays, clinical validity is the standard. The future will be the explainability of these models. How can we as builders of these models, helping this knowledge building. And there is the patient perspective. Every one of you here was, is, or will be a patient at some point. How you will be deciding about your care if you don't know what exactly your options are providing to you, or how that options will, how those options got to that point where they are recommending something. If you are undergoing surgery, the surgeon will explain to you, these are the risks, these are not the risks, you can bleed, you can do this, based on this, based on the technique, because you have these conditions, and They have the entire process to explain to you. And even when they know everything, or they think that they know everything, they will say, but there is still a chance that you die. How are you explaining to a patient enough that the patient has enough information to make a decision that they will rely on an AI application to actually inform them? For example, how much insulin are you receiving in the next hours? And if you have an AI delivering insulin, I suppose you have an AI insulin pump, and then that is the dream, I guess, that we don't have the solution yet, but imagine that the insulin pump is reading our glucose levels, and based on that, will calculate how much insulin you will receive next. How are you trusting that? How are you trusting that the AI will capture everything that is possible for you, that you receive the right amount of insulin next, that you will not have a hypoglycemia, and you will be in shock in the hospital, or you have a hyperglycemia that you can end up in the hospital as well? How are you explaining to the patient that you can trust in that little thing that is attached to your body and they can trust? So if you cannot explain to clinicians, how can clinicians explain to patients? How can patients rely on clinicians in that case to make a decision for them? Because they trust. Patients trust on clinicians on their decision. I work a lot in transplantation. We don't have a lot of solutions. And patient will ask the surgeon, do you think that is a good time for me to go right now? Do you think that the transplant will save my life? My dream is to have a very smart system that will provide some decision to patients. But the other question is how I will build a model that actually can have the information to show to the patient, helping the clinician on that decision, that actually can explain why that decision or that probability of going this direction or in that direction is possible. I told you that there are more questions than answers in this talk, right? And then there are ethical implications. In healthcare, we are driven by principles of biomedical ethics. And these are the four main concepts that we follow. The autonomy, and that is about patients' autonomy. And that is based on how do you give autonomy to patients that they have informed consent. That means that they will consent in receiving care. Doesn't matter if it's a blood collection or a surgery, but how are you consent to have that application, that intervention based in being informed of what really you are receiving. The beneficence goes along very well with non-maleficence. How much that intervention will do you good and not doing bad. And the sense of justice. And that goes back to what we have been discussing a lot lately. How can we capture equity, health disparity? How can we make sure that our AI model will deliver a fair model, a fair direction to that patient that is not biased? And that brings me to the next one, that is a very common picture that can be used for many things. But these pictures, according to this source, the main distinction between the draft and the final version of a model, of a publication, of a study, how much bias actually is included there. That's from the AI algorithm and the data used to train them. How much is in the human that actually selected or helped to select certain features. But then you may say, I didn't supervise modeling, so I didn't participate in anything. I let my model select. But what kind of data did you have there? And now you get to the data, because that is my thing. I work a lot with data. But how are you having everything in your data? Can you have everything in your data that represent a patient or not? So how much systematic bias, human bias, actually is reflecting your results, and that reflecting in your bias result? So there are many ways of introducing bias. Of course, we have the existing human bias that is transferred in all aspects of a modeling. And even when you think that is not, you are looking into the data with some kind of lens that is already built inside you, and that is based on your trajectory in your life and what you learn. How can you leave that bias at the side? So here on the left top corner, we can have the world as introducing bias to your model. So real world pattern of health inequality, discrimination, people that don't have equal access to care, the discrimination on the healthcare processes, how many people get to the door with the same condition and have different direction on the way. Clinician bias in making these decisions. I work with transplant patients. Those patients are already a very selected bias population because they make through the listing. I'm not looking the ones that never made through the listing. I never looked, and it's very hard to find those patients that actually, they were never told that they will maybe be able to receive a transplant. How many of those that actually got to that next step that was referred to a transplant center, got to the transplant center, and maybe the transplant center based on social, economical, family support, decided that maybe that is not a good patient for a transplant. How those decisions are made? Data. Sampling bias, we don't have a sample of everything. We have data that I talk about the health disease data, because we have disease data, we don't have health data. The design, how we introduce bias on the design of our study, and the use. After you design, how that is used, how that is implemented, how that is delivered to patients. So the state of our data nowadays that we use to build that AI, so if you are a model builder, you know that you rely on data, right? So healthcare data, we have missingness, sometimes random, sometimes non-random. Sometimes people even don't realize that there are different types of missing data. Lack of full representation of the conditions that patients have, full representation of the patients per se, full representation of different degrees of populations, lack data elements to capture the whole person. We are very much focused in the disease still. False positives, false negatives. I remember about an example that I used to explain in my stats class about what means false positives and false negatives. And that is a very different situation. If you have a case in front of you that can be a meningitis, that you can die, if you have a false negative, or it's just a cold, that you likely not die from a cold. So depending on the condition, depending on what is your decision point, you may consider how much false positives or false negatives, how much accuracy do you need in your model. And there are, of course, random errors that are a result of all this process. How can we address this? This is our data. Our data is these different things, and we try to just apply a model to everyone. How can I be building an equitable model if you don't have equitable data? And then we have health disease care data. And I remember when I was about to send the title for this talk, and I used to say, is unexplainable. And then people say, no, you should not do this. Nowadays it's unexplainable AI. But in the healthcare data, it's not healthcare data, it's health disease data. Our healthcare facilities, they care people that are sick. People that are healthy, they don't get to our EHR. That is the main source of data, granular data, that you can build better personalized models of care. Where are the social inequalities that we find in our population? We don't have in our data. The institutional inequalities, access to care, people that live in rural, people that live in urban, people that live close to the Mayo Clinic, and people that live close to not that better, like Mayo Clinic deliver the best care possible to patients. And if you don't have access to that, living conditions, how living conditions, and I'm not even talking here much about race and gender. I'm talking more about common grounds. Do you live in a healthy living environment? How about pollution? How about sanitation, water, soil, risk behaviors, disease and injury? All that we have. So this bit here, the second to the last, is what we have. Disease and injuries. That is what we have. And that is the piece that we capture from everything. And of course, we have mortality, what is not accurate as well. Today is my last day of 8 days of conference, and I jump around 3 different conferences, 3 totally different and totally different audience. I come from the American Transplant Congress, 90% surgeons, 99.9% doesn't even consider to use machine learning, AI, or EHR, or anything. Then I went to a Nursing Knowledge Big Data Science conference that I co-chair. Nurse informaticians thinking ahead of time. That is probably less than 1% of the nurses in the country. They try very hard to put some seeds in nurses' mind about the potential of using data to improve patient outcomes. And then I come here, that I believe 99% has a computer science direction or have a more modeling direction. So I look back and I see how this three worlds that are very different can talk to each other? Can we put all three of us together in a room or in a convention center and try to solve problems and problems for patients? And we are not talking even about problems for clinicians. We are talking about saving people's lives or just improving their lives. How can we do that? Data is still limited. So EHR data, to capture EHR, first is a very small representation of what we have available that actually play a role in how people live. But when you look to the EHR, you also see that it's very disparate. This is just a representation of what I have in my transplant population, where almost 75% of this data that I have, they are physiologic. They are just ICD codes, procedures. I don't have community. I don't have how much nutrition support they have, physical therapy support they have in the community that is very important for their recovery. I don't have the environment, and I don't have even the security, how patients feel secure or not to ask for help. What are the potentials for data improvement? So if we need data to build explainable AIs, not just explainable, but that can capture and represent and give good results that can actually inform, we can link different sources. And I think interoperability is the promise. This is low. We can link hospital, public, community, and other sources of data, all these wearables that we use. I have a lot of information in my watch. Guess what? I cannot transfer this to my Epic system. Can we do that? To my chart? No. Pharmacy. Our pharmacy data that patients refill outside is not linked. And that is not even the start of the problem. Just because patients refill their medication doesn't mean that they take their medication. Insurance. How much money people expend in healthcare? How many times did you hear people say, oh, that's too expensive, I'm not doing. Let's see what happens. Right? Socioeconomic. Good food, healthy food, water, and even more that I cannot think about. And probably there will be more coming. So what kind of problems AI can address? Many problems. And I will put my nursing hat that usually is not very nursing because I do transplantation and nurses don't like transplantation, I guess. But we have really big problems that doesn't matter the condition that patients have. They can have transplant, they can have surgery, they can be old, young. Patient falls. Why patient falls? That's an unsolved problem. And that impacts patients, impact families, and impact what is the most important in the business of medicine, money. Because if a patient falls, they don't get reimbursement, delay, discharge. In the community setting, patients falls and pressure ulcers are huge. And they are penalized for those metrics. How can AI really help to not just detect patients that are in risk for fall, but prevent fall? I have been talking to people lately, and is this recorded? It is? Okay, so I will just be cautious about what I'm saying. But like I have good friends that do robotics, and we talk about building robots that can be used for safety and so on. And I always think about preventing major problems like falls, pressure ulcers, or pain But they say, I talk to people and people say, my mom cannot walk, and those walkers are terrible. Why can we not build a smart walker that actually help people to have a good positioning? Because the way that people use walker nowadays, I think will just damage even more their back, because they are all, the positioning is terrible. They cannot go up and down stairs. If they go to the street, to the sidewalk, they cannot move because the terrain is not plain. How can we use the technology to actually simple solutions that will not just prevent falls, but to improve the quality of life of these people? So healthcare systems are complex, and while AI is trained to work as we think that we will to work, this does not mean that it will work for every patient or for every condition that patients have. And so we have to take that into account. So there are a couple of initiatives that are looking specifically in nursing. One is the Nursing Knowledge Big Data Science Conference that it did end yesterday, and it's a year-round community of thinkers that challenge data sharing, capturing social determinants of health, and other important aspects of the nursing care and patients in the continuum. And recently we founded the NAIL Collaborative, that is the artificial intelligence in nursing. So 3 years ago, we invited a couple of bright thinkers to Geneva, and in 3 days, 20 people sat together to think what are the priorities and opportunities to actually redefine the use of AI in nursing. And you may think, why nursing? I know who bills are the physicians. But do you know who stays 24/7 with patients? Nurses. Although physicians prescribe, physicians, they have the role. If nurses are not included in this development, how they will address patients. So we have been very strongly collaborating in several venues to reinforce the use of AI in nursing, and how can we educate nurses in the use of AI? What are the competencies that they need to know to actually use an application in the delivery of care? And this work was published last year, so if you have a chance to take a look. But we call for the use of AI to help nurses to decrease the burden of the work that clinicians, not just nurses, have at the front line. And this week as well, so we're starting next week, and I'm not going because I'm done, but my colleagues are developing, and I'm one of the developers, I will just not be there, the first workshop on artificial intelligence in nursing. So we want to incentivize nurses to be more active in the AI development life cycle, because otherwise I don't think that we will be able to implement if we don't participate in the process. And I will go back to that. So I would like just to give an example of what we can do. So this is a result of one of my study, and then you may look this picture and say, yes, clearly, the redder, the sicker, and I can see there are clusters here that are directed to several body systems. But show this to a clinician. Very beautiful. But then you ask, actually, how much one is more important than the other one? They want to know what exactly in the circulatory system actually is driving that circulatory system to be impactful in the outcomes. Just knowing the circulatory system is impactful doesn't help. They want to know, is the blood pressure, heart disease, how much? If you have a patient with 2 conditions, How do you decide which one is more important? Let's suppose you have to pick one. You have to have that information. So sometimes you need to show many times, and most of the times, 100% of the time, you have to show the degree to which variable and how much that variable weight on the result. Using different models, you can use good things, very traditional ones like a regression model. And then you can combine with some other models that are not that, and probably if you were the last ICH, I actually presented this work. But if you just show this figure to a clinician, he probably will sit and just say, okay, that's good. But then you want to have to explain that actually, what are all these bars? And that is where you need to have the weight of what each feature, how much weight it does in that final model. And then, of course, you have to speak their language. You have to talk about error, median, mean, but that doesn't represent the majority, right? What does happen with who doesn't, who is not there, with those 16% that you didn't detect? What are the options? Can you compare to another condition? You have to have real world examples to illustrate that. I can predict this diagnosis, and I have that many that I cannot predict. I can have an error. But then what do you do with those errors? What are the solutions for that? You just leave it alone? No, you can provide a solution for that, or another way to treat and how to diagnose that missing solution. And one of the things that I believe that is one of the most important things to build trustful and explainable AI is a team science. And the team science include clinicians since the start, since the problem generation. It's about explaining to clinicians, what do you want to develop? Is seeing their perspective, how that can be developed. Help them to participate in the future selection, saying, understanding if that future is important or not. How much important is that or not? The validation of those fields. I work basically with computer scientists, and when we start a project, if the person is new to the project, they don't know that saturation cannot be more than 100%. They don't know that saturation can be less than 0. How do you validate those fields? The weight of different features, model understanding, then use of similar models as I talked before. How do you do the interpretation of these results? How do you use these results? And the clinical validation, use real world use case, simulations, then people can understand. So takeaways from this today, from my perspective, I have to say, I don't believe there is a recipe nowadays for how we do this. I think it's a teamwork in the sense that together we build this common understanding from the start to the end. And I think the inclusion of the clinician since the start reflects a lot of the acceptance of the result. I work directly with the clinical side all the time, and that changed the way that they see your work, because they see you working. And then they will explain to their peers what you're doing. And it's a totally different reception than if you explain to them. Interact with the end user, interact with the clinicians working with the end model that you want to build. Patients, think about the patient-centered approach. understanding the need and the limitations of what you are doing, and understand that it's a known world for clinicians. They work already in an unknown world where the uncertainty, the probability is very heavy, and you are introducing another one. So think about that. I had a couple of support for this research for just a couple of slides, and here's my information. If you want to connect with me, I have a lot of data, by the way. If you want to do any project, I will be happy to help you with that. And I think I'm open to questions if you have any.